Hey guys, it's Medicosis Perfectionalis. We are back to resume our discussion about pulmonary medicine or pulmonology. In previous videos, we have talked about bazillion restrictive lung diseases. Actually, they are more than 100 diseases. Today, it's the last lecture of restrictive lung diseases. We'll talk about rheumatoid arthritis and lupus. We'll talk about Langerhans cell histiocytosis, also known as histiocytosis X, and Lymphangioleiomyomatosis. Who named these things anyway? Langerhans cell histiocytosis is more commoner in men. Lymphangioleiomyomatosis is more common in women. With that being said, now let's get started. Lung diseases are divided into obstructive and restrictive. We are here. Restrictive is divided into extrinsic and intrinsic. Intrinsic is divided into parenchymal and non-parenchymal. Parenchymal is divided into occupational, idiopathic, and others. Today we'll talk about those others. Sarcoidosis has been discussed in the previous video. Today we'll talk about rheumatological, Langerhans cell histiocytosis, lymphangioleiomyomatosis, vascularities, and even the eosinophilic interstitial lung diseases, such as eosinophilic pneumonia, which has acute and chronic subtypes. 30% of patients with rheumatoid arthritis have a restrictive lung disease, which is an interstitial pulmonary fibrosis. The most common pulmonary abnormality in rheumatoid is actually pleuritis or pleurisy, which is a freaking sinusitis with the famous biphasic friction rub. Inhalation, exhalation. This is the biphasic friction rub. The most common cardiac abnormality in rheumatoid is the freaking sinusitis, now called pericarditis, and this one is having triphasic friction rub. Systolic, early diastolic, late diastolic. Lub-dub, lub-dub, lub-dub. Triphasic friction rub. Let's say that you're hearing a friction rub, you're not sure if it's biphasic or triphasic, you're not sure if it's pleuritis or pericarditis. Ask the patient to breathe in and hold his or her breath. If the friction rub disappeared, it was pleuritis, because the heart is still pumping, by the way. If it did not disappear, this is pericarditis. The pleurisy can have pleural effusion or it cannot, and when it has pleural effusion, it's an exudate. It's not a transudate, and this is going to be the topic of the next video, pleural effusions, with 4 main subtypes: exudate, transudate, chylous, and pseudochylous effusions. Okay, back to pleurisy. If there is pleural effusion, it's exudative. Pleural effusion in rheumatoid has low glucose level. It comes on the exam all the time. Very, very important. And usually less than 60, the glucose level in the effusion, not in your blood. Pleural effusion in rheumatoid has pseudochylous finding, not chylous. So it's lacking in chylomicrons. It's lacking in triglycerides, but it has a lot of cholesterol. That's why it's a pseudochylous, and we will discuss this in the next video. Upper lung fields, you have necrobiotic nodules. Pulmonary complications caused by the treatment or the therapy of rheumatoid. If you're giving the patient methotrexate, be aware of interstitial pulmonary fibrosis and mucositis. If you're giving gold, it's historically, of course, it's interstitial pulmonary fibrosis. Why historically? Because gold sucks in treating rheumatoid patients, and gold is a horrible investment. I don't believe you. Okay, here is from Dr. Thomas Sowell, the senior economist at Stanford University, so shut up. If you have invested $1 in gold in year 1801 and you left it until year 1998, your investment would have been worth 78 cents, not even $1. You have lost money. If you have put the money in U.S. Treasury bonds in 1801, just $1, it would have been worth $1,000. If you have put your $1 in United States stock market, by year 1998, you would have $500,000 freaking dollars. Keep hoarding your gold. Penicillamine can lead to cryptogenic organizing pneumonia, and we have talked about COP in previous videos. Kaplan syndrome is a triad of complicated coal-worker pneumoconiosis plus rheumatoid nodules in the lung plus rheumatoid arthritis. Those rheumatoid nodules can cavitate. Rheumatoid arthritis actually increases your risk of bronchogenic carcinoma. Let's talk about lupus, restrictive lung disease, pleurisy, which is painful and bilateral and biphasic. Wow. Atelectasis, hemoptysis, acute lupus pneumonitis, orthopnea that's out of proportion, on that chest x-ray. So chest x-ray is very benign findings, very mild disease, but the orthopnea, man, the patient is yelling at you. Pulmonary arterial hypertension. A young lady with unexplained serositis has lupus until proven otherwise. Those are words of wisdom from Dr. Edward Golion. If lung and pleural involvement, lupus has become even more plausible, because if it involves the lung and a pleura in a young lady, this is probably lupus. So lupus should be on top of your list until you rule it out. Systemic sclerosis, the old name is scleroderma. If your professor still uses this term, it means he's living under a rock. Sorry, professors, I always love messing with you. It affects the lung in 100% of cases, causing interstitial pulmonary fibrosis. Also, sarcoidosis involves the lung all the time. No pleural effusion with systemic sclerosis. Wow. Pulmonary arterial hypertension, that's out of proportion of the interstitial pulmonary fibrosis. You do the chest x-ray or the CT, a very mild fibrosis. But the pulmonary hypertension, man, is ugly. Why pulmonary hypertension in systemic sclerosis? It is not because of the interstitial fibrosis. It's actually due to intimal proliferation of the pulmonary artery. Happens in systemic sclerosis big time. You have two types of systemic sclerosis: limited, which is CREST syndrome. You have isolated pulmonary arterial hypertension. But in diffuse, it's called diffuse, so it involves many organs. You'll have pulmonary arterial hypertension plus interstitial pulmonary fibrosis, that's why we call it diffuse, plus other symptoms in other organs, including the kidney. Big time. And if you have a patient with systemic sclerosis and kidney problems, give them ACE inhibitors. These drugs work like magic for these patients. I don't know why, but they do. GERD and aspiration are seen in systemic sclerosis. Systemic sclerosis increase your risk of bronchogenic carcinoma. The most common cause of death in systemic sclerosis is lung disease, not the kidney. Why not the kidney? Because ACE inhibitors are magic. Let's compare between Langerhans cell histiocytosis, which is commoner in male who smoke, and lymphangioleiomyomatosis, which happens in premenopausal female. Pneumothorax is very common with LCH, less common with LAM. Thoracic duct involvement is very rare with LHC, common with LAM. Chylous pleural effusion is less common with LCH, more common with LAM. Okay, so thoracic duct involvement and chylous effusion, they go together. Lung involvement. In LCH, you have honeycombing or small cyst in upper lungs. And remember, my mnemonic: smoke goes upward, so it's the upper lobes. In LAM, you have honeycombing all over the lung. LAM laments the entire lung. And look at this name, Lymphangioleiomyomatosis. It's a very long name. Of course, it's gonna involve the entire lung. Duh. Diabetes insipidus. Yep, you will not find it with LAM. Langerhans cell histiocytosis has lytic bone lesions, but LAM does not. LCH is not linked to tuberous sclerosis, but LAM is. S100 antigen is positive in Langerhans cell histiocytosis, but it's negative in LAM. Burbick's granules, also known as tennis racket granules, are found in LCH, but not found in LAM. And here is my horrible mnemonic. I do apologize. It's just my way to remember it on my exam. If it works for you, that's fine. If it doesn't work, it doesn't. Histiocytosis X is commoner in men, has the tennis racket granules, and it's associated with smoking cigarettes. If it's called Langerhans cell histiocytosis, you think we'll find Langerhans cell? And the answer is yes, but it's no in lymphangioleiomyomatosis. Management: you stop smoking. Man, stop it. And if this fails, or if he's stopped smoking and still not improving, you can try steroids. In lymphangioleiomyomatosis, you do oophorectomy and progestin treatment, and you do lung transplant. By the way, even after doing the lung transplant, LAM can come back again. LAM laments everything, laments the entire lung, and laments every lung, including your new lung. Langerhans cell histiocytosis is the same freaking thing as histiocytosis X, but please do not confuse histiocytosis X with syndrome X, also known as metabolic syndrome. PFTs also increase lung volumes and capacities, which is really weird. Why? Because in any restrictive lung disease, there is decreased lung volume and capacities. Histiocytosis X is an exception. That's why it's an X. It's vague. It's hiding in the ether. Maybe the increase in lung volumes and capacities is related to the fact of playing tennis. I mean the tennis granules. which is a silly joke, but it works. LCH is probably the only restrictive lung disease with increased lung volumes. Let's talk about LAM, Lymphangioleiomyomatosis. Let's break that down. Lymph means there's lymph. Angio means it's a lymph vessel, so it's a lymphatic. Myo means muscle. Leiomyo means smooth muscle. Atosis means a condition. That's why the name of my channel is Medicosis. It's a condition of medicine, which is weird. Proliferation of immature small muscles. Imagine my shock. In the bronchi, alveoli, blood vessels, lymphatics, dilatation and constrictions. Involvement of the thoracic duct will lead to chylous effusion in the pleural cavity. If it's chylous, you'll have lots of triglycerides, lots of chylomicrons, but very few or very little cholesterol. You might see chylomicrons in the pleural cavity, no kidding, even after, if it's called chylous effusion, it has chylomicrons. Even after lung transplant, LAM may occur again. LAM laments the lung, every lung, the entire lung, all the time. Vasculitis-induced interstitial lung disease. Let's talk about these vasculitides. Sophisticated stuff. Granulomatosis with polyangiitis, also known as Wegener, or the C mnemonic, so let's call it Wegener. And everything here is C. C-ANCA, which is antiproteinase 3. There is the third letter in the alphabet and the third number. C-ANCA, antiproteinase 3, detected by ELISA, which shamefully contains 5 letters, not 3. Caucasians, Northern European descent, sex congruent, which means male equals female. Neutrophil infiltration on biopsy. Contrast that with Churg-Strauss, where you have eosinophilic infiltration. Everything here is a C. You have involvement of the nasopharynx, lung, and kidney. So here is the nose, here is the lung, and here is the kidney. And if you see, they form a C shape. Nasopharynx, lung, and kidney. You are coughing up blood, and you are peeing blood. Hemoptysis and hematuria. You have scleritis, conjunctivitis, ulcer, discharge, and even perforation of the nasal septum. So you have sinusitis, you have hemoptysis, cavitary lesions bilaterally, kidney, you have necrotizing, rapidly progressive glomerulonephritis, which is also known as crycentric, leading to chronic kidney disease, and you can also have strawberry gingivitis. Treatment with corticosteroids, cyclophosphamide, and CD20 antibodies such as rituximab. Be careful because cyclophosphamide leads to hemorrhagic cystitis, which will also lead to blood in the urine. And it can also lead to suprapubic tenderness. Okay, let's talk about eosinophilic granulomatosis with polyangiitis. The old name is Churg-Strauss syndrome. Here is the P-ANCA, not the C-ANCA. Necrotizing small vessel vasculitis, eosinophilia, not neutrophilia. It can coexist with asthma, very important, and of course asthma is related to eosinophils because this is type 1 hypersensitivity reaction. Okay, how would you unmask the hidden eosinophilic granulomatosis with polyangiitis if the patient has asthma? How do you know it? Okay, treat the asthma with a leukotriene receptor antagonist, and here's the trick. While simultaneously weaning oral corticosteroids, when you remove the immunosuppressant, the immunological diseases will become active, helping you to diagnose it. Oh, that was neat. Treatment, same thing, immunosuppressants. Restrictive lung diseases, extrinsic and intrinsic. Intrinsic is diffuse parenchymal or non-parenchymal. Diffuse parenchymal, we have talked about all of them, baby, except the eosinophilic interstitial lung disease, such as eosinophilic pneumonia, but we have talked about allergic bronchopulmonary aspergillosis in a previous video in this playlist called Pulmonology, and we'll talk about alveolar proteinosis and anti-glomerular basement membrane antibody, also known as Goodpasture syndrome. Eosinophilic interstitial lung disease divided into 3 things: eosinophilic pneumonia, allergic bronchopulmonary aspergillosis discussed before, eosinophilic granulomatosis with polyangiitis discussed 2 minutes ago. Eosinophilic pneumonia is then subdivided into Loeffler syndrome, acute eosinophilic pneumonia, and chronic eosinophilic pneumonia. Loeffler syndrome has acute transient pulmonary eosinophilia. You'll see it with ascaris, strongyloides, or any parasitic infection, and it's self-limiting. Thank goodness! No treatment necessary. If it ain't broken, don't fix it. If it's severe, give steroids, because what else should we do? When in doubt, give steroids. Acute eosinophilic pneumonia. Acute lung disease. It's called acute. Fever. Hypoxemia. Similar to ARDS because it's called acute. And you'll find eosinophils because it's called eosinophilic pneumonia. It makes perfect sense. If it's eosinophilic pneumonia, alright, immune-related, give steroids. and mechanically ventilate if it's severe because it's acute. Chronic eosinophilic pneumonia, that's subacute chronic form, a milder form, less severe than acute. You'll find wheezing, cough. The most common eosinophilic pneumonia is chronic eosinophilic pneumonia, found in adult females, extremely high ESR. Why if it's chronic? I have no idea. ESR is a garbage test. Watch my video on ESR. Chest x-ray, you'll find bilateral infiltrates. How would you differentiate between chest x-ray pattern in pulmonary edema or chronic eosinophilic pneumonia? Because both of them have a butterfly pattern of infiltrates. Here's the trick. In pulmonary edema, the butterfly is light. It's opacified, so it appears white. Here, in chronic eosinophilic pneumonia, the butterfly is black. And of course, your professor did not tell you about this teeny tiny distinction. That's why he's just a professor. Idiopathic pulmonary hemosiderosis. Okay, siderosis means a condition of iron. Osis condition, sidero means iron. Interstitial lung disease. Okay, clinical triad of hemoptysis, iron deficiency anemia. Okay, because when you cough blood, you're losing blood. Blood contains what? RBCs. RBCs contain what? Hemoglobin. Hemoglobin contains what? Heme and globin. Heme contains what? Iron and protoporphyrin. So when you are losing blood, you're losing RBCs and you're losing iron. That's why you get iron deficiency anemia. And you have diffuse parenchymal infiltrates. Recurrent bleeding into the alveoli will lead to iron in the alveoli, hemoptysis, iron deficiency anemia, iron in the alveoli called hemosiderin-laden macrophages, more blood, more RBCs, more hemoglobin, increased DLCO. Because now when you have more hemoglobin, you have more capacity to bind with the carbon monoxide. Watch my video on DLCO, diffusion capacity of carbon monoxide. Goodpasture syndrome, also known as anti-glomerular basement membrane antibody. And of course, glomerular basement membrane has type 4 collagen because type 4 is in the floor. Non-interstitial lung disease, it's alveolar, it's not parenchymal. There are antibodies against the basement membrane in the alveoli and the basement membrane in the glomeruli. Against the basement membrane of the alveoli leading to hemoptysis, and against the basement membrane of the glomeruli will lead to hematuria. Blood is coughed up, blood is peed out. If there is more blood, there is more RBCs, there is more hemoglobin, there is increased DLCO. With medicosis perfectionalis, we tell you everything in medicine. We do not ish. If it's ish, it's a wish. Idiopathic pulmonary hemosiderosis versus Goodpasture syndrome. Okay, here we have no O2 antibodies, but here you have O2 antibodies against alveoli and against glomeruli. You have alveolar bleeding leading to hemoptysis in both of them. Idiopathic pulmonary hemosiderosis is only in the alveoli. It does not affect the kidney. There is no hematuria. But here in Goodpasture, there is hematuria. Both of them will have increased DLCO. Very important. Let me ask you a question. There is an obstructive lung disease that also has increased DLCO. If you said severe asthma, you are absolutely correct, because in severe asthma there is revascularization. When there is revascularization, you have more blood vessels. And you have more blood vessels, you have more blood. When you have more blood, you have more RBCs. When you have more RBCs, you have more hemoglobin. When you have more hemoglobin, you have more heme and more globin. When you have more hemoglobin, you can bind more carbon monoxide. Some clinical pearls. Young lady with unexplained histiocytosis has lupus until proven otherwise. If you find involvement of lung and pleura in this lady, lupus has just become a more plausible explanation. Lupus has just jumped to the top of the differential diagnosis. I apologize about my street language. I know I don't sound like a doctor. I sound like your buddy from the bungalow. That's why you guys love me, because I'm simple. I'm not like your arrogant doctor who looks down on you while his eyeglasses are hanging down very low over the tip of his nose, causing chronic rhinitis and anosmia. Never ever give a doctor a flower. Here are some questions. Please mention 6 diseases that cause a transudative pleural effusion. What are the Light's criteria? What is their clinical significance? What's the most common cause of an exudative effusion, pleural effusion, in the United States? Let me know the answers in the comment section. You'll find the answers in the next video when we talk about pleural effusion. Alright, Medicosis gang, thank you for watching. Please subscribe, hit the bell, smash like, follow me on Facebook. I have 100 cases there. You can get my Dropbox notes at patreon.com/medicosis. They include premium videos, cases, post notes, PDF notes, audio notes, even the slide of this video, and every other video. Thank you so much for watching. As always, be safe, stay happy, and study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.